program. It's a great day to be alive. It's 12 o'clock here in Rochester, Minnesota at the Mayo Clinic, and it is 7 p.m. in Amsterdam and 6 or 7 p.m. in London. Wherever you are across the globe, it's great to have you with us. I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic in Rochester, Minnesota, and director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and its Sudden Death Genomics Laboratory. And on behalf of Alice Laura, who you see in the screen there, hello, Alice, our CEO of the SADS Foundation, the Sudden Arrhythmia Death Syndrome Foundation, it's great to have you with us for this webinar on clinical recommendations for evaluating the living, those patients who survived sudden cardiac arrest and their families, as well as the evaluation for the dead, those who have experienced sudden unexplained death. What does their evaluation look like, and that of the decedent's family members? And there are no two people better in the world to do this than my dear friends, Professor Arthur Wilde from Amsterdam and Professor Elijah Behr from London. So we're grateful to them for taking the time on, in the Netherlands, the King's Day. So this is King's Day that he should be celebrating the King, but he's celebrating this topic with us. So we're really appreciative of them, all of their contributions to this work, to the SADS Foundation, their commitment to us and our efforts at the SADS Foundation. We could not do these webinars if it wasn't for the generous educational grants from Invitae and Medtronic and their unrestricted support of this webinar and webinars like it. So thank you, Invitae. Thank you, Medtronic. And speaking of thank you, if you, the participants, would like to show your thank you, it's really easy. If you derive benefit from this 90 minutes together and it's been of value to you and your career and your patients, show your appreciation. Go to the SADS Foundation website, www.sads.org. It's very obvious. Top right corner, it says donate now. The color is red, and even if I'm colorblind, which I am, I can see the box and I can click the donate now. So feel free to partner with us at the SADS Foundation. Professor Wilde is going to get this started first, and then Professor Behr. Arthur is the chair of the Department of Clinical and Experimental Cardiology at the University of Amsterdam in the Netherlands. His clinical breadth is tremendous in the field of sudden death predisposing genetic heart diseases and the care of patients with those. He is a bench to bedside scientist and translational scientist and clinician, published over 550 papers. I've had the good privilege of publishing some of those with them. He was inducted into the Dutch Academy of Science in 2011, and in 2012, he received the prestigious Distinguished Investigator Award from the Heart Rhythm Society. He also is my first Winland Smith Rice Cardiovascular Genomics visiting professor, and we had a great time when he was here. Professor Behr, Elijah, is another dear friend of mine. In fact, on Twitter, there are only 2 of 3 named dear friends of mine recently. And so these guys are really special to me. Elijah, like Arthur, is known throughout the globe in our field of sudden death predisposing genetic heart muscle and heart rhythm diseases. He's the professor of cardiovascular medicine at St. George's Hospital, University of London in London, England. He directs their arrhythmia service and co-directs their inherited cardiac conditions clinic at St. George's. Elijah is also the newest member of the Department of Cardiovascular Medicine at, yes, Mayo Clinic. He is staffing a Mayo Clinic London and bringing our Winland Smith Rice Genetic Heart Rhythm Clinic to Mayo Clinic London. So it's great to have Elijah as part of our Mayo family. His research interests are extensive in all things genetic heart disease, Brugada, Lon QT, cardiomyopathy, sudden death risk stratification, And both of them played critical roles in the guidelines that have just been published, the consensus statement about this very topic of how do we evaluate the survivors of sudden cardiac arrest and their families? How do we evaluate those who died and their families? Arthur chaired this document, co-chaired this document, and Elijah and I had the privilege of serving as contributors and co-authors of this. So, Min, you are giants in my life. I treasure our friendship. I'm grateful for all that you've done on this topic. And Arthur, it's your turn to take it away for the first part, and then Elijah, and I wish you all the best in the question and answer session. And for all of those joining, thanks for joining us, and hit that donate now button at the very end. Take care, everyone.
Thank you very much, Mike, for this too kind introduction. And so the welcome all. The topic is the consensus document with the clinical recommendations for evaluating patients with sudden unexplained death or sudden cardiac arrest and their families. So this is, and it has been an initiative from the Asian Pacific Heart Rhythm Society, and it was chaired by Martin Stiles on their behalf. And I had the privilege to chair it on behalf of the US Heart Rhythm Society. And then it was further developed in collaboration with a number of other societies, among which the European Heart Rhythm Association, ERA, the European Society of Human Genetics, and the Latin American Heart Rhythm Society. So it's a global effort, and the number of authors, or the different authors, are here on this list. And as you can see, they are from different countries around the world. To make this more easy, this is the world map. So authors from the United States, from Canada, from Brazil, from Europe, different countries in Europe, and different countries in Asia, among which China, Japan, Thailand, Taiwan, Australia, and New Zealand. So the methodology is common to all the consensus documents as they have appeared over the years. And it starts with a writing committee that reviewed the evidence and established the consensus to generate recommendations. And all these recommendations are presented in a modular knowledge chunk format, with each chunk including a table of those recommendations, a brief synopsis, some supportive text, flow diagrams and tables as appropriate, and obviously references. The recommendations are formulated according to the American College of Cardiology and the American Heart Association. And this is, I think, familiar to all of you reading consensus documents. Recommendations can have a class 1, which is a strong recommendation where the benefit clearly is above risk. A class 2A is a moderate recommendation, and class 2B becomes more weak. And there is a class 3 that either is no benefit or even harm, and then the risk is higher than the benefit. Then there is level of evidence, which is level A, and that is supported by more than one randomized clinical trial. And obviously in the field of cardiac arrhythmia syndromes of inherited heart disease, there's not a single randomized clinical trial. So there will be no recommendation with a level A. Level BR is there because there are some meta-analysis of work that has been done, and there is, but most of it is level C, and that is so limited data or even expert opinion. And then all the recommendations had a preset threshold, which was considered 80%, but as a matter of fact, the 74 recommendations were balloted by the 28 writing committee members and approved by an average of 94%. The table of contents is here. There is an introduction, there is a section on epidemiology of sudden cardiac death. Then there is a section on importance of multidisciplinary teams, on counseling of the families and the bereaved and the newly bereaved, the impact of and the importance of psychological care, and then there is the investigation of sudden death itself, investigation of sudden cardiac arrest survivors, and the investigation of the family. And the final chapter is on the future directions. In this 1 hour that we have together, we will discuss chapter 3 to 8. I will discuss chapter 3 to 6, and my colleague Elijah will discuss chapter 7 and 8, and we will not go into detail about chapter 1, 2, and 9. So I'll start with the importance of a multidisciplinary team. That is section 3 in the document. And it starts with these two recommendations, both for class 1. And that is that the investigation of a sudden unexplained death or sudden cardiac death due to potential heritable condition should be overseen by a multidisciplinary team with, as a minimum, appropriate expertise in pediatric and/or adult cardiology, genetic counseling, and pathology. And the same holds for the investigation of a sudden cardiac arrest survivor, where there is an heritable condition possible. The same multidisciplinary team is pertinent, with the exception of pathology, because when they survive, when the cardiac arrest individual is still living, you don't need the pathology. So the multidisciplinary team here in the schematic drawing includes a clinical leader, a lead coordinator, adult and pediatric cardiologists, genetic counselors, and/or clinical geneticists, depending on the country where you are working. And it should also have access to psychologists or social workers. If you increase it a little bit, you can add pathologists, clinical scientists, or non-cardiac specialists as needed. For example, a neurologist can be important if the decedent also had some muscle weakness, for example. And all this usually is conducted in a university setting with research links and molecular genetics on site. And there are countries like mine where we do the molecular genetics ourselves and do not rely on a commercial molecular genetic as you do in the United States. So the multidisciplinary team has regular meetings here in the middle. The sudden cardiac death or the resuscitated sudden cardiac arrest victim is seen, or information is put together by the cardiogenic service coordinator, and the information is brought into the multidisciplinary team meetings where all the individuals are there that I just mentioned. The coordinator is also in contact with the patient and/or next of kin, and the multidisciplinary team discuss all the evidence available and then ultimately make a report with the results of the familial, clinical, and genetic investigations and conclusions of the multidisciplinary team. The multidisciplinary obviously also liaises with the family primary care if needed, with the specialty disciplines and with the community-based service, or with the coroner in the case of a sudden death, with the coroner or the forensic medical examiner. And that brings me to counseling. Whenever you start doing investigation in families affected by sudden unexplained death and sudden cardiac arrest, genetic counseling is strongly recommended, class 1 recommendation. And for all families where such a tragic accident had happened and an heritable cause is suspected. And this counseling should include ante-mortem and post-mortem data collection and evaluation so that risk, benefits, and results of clinical significance of genetic testing can be discussed. And this is more or less a similar recommendation. The role of psychological care is emphasized, and this is the first consensus document where psychological care is even mentioned. And it's considered by all of us important with a class 1 recommendation that at least assessment by a healthcare professional trained in psychological evaluation and treatment to the patient and immediate family members is relevant when there is an investigation of a sudden cardiac arrest with a potential genetic cause. When the decedent, when the individual died, so in the setting of unexplained death with a potential genetic cause, it's a class 2A recommendation. So psychological care, access to psychological care is considered very important in this setting. That brings me to chapter 6, which is the investigation of sudden death itself. And that all starts with getting the data on the history of the person who died and the family. And both of it is a class 1 recommendation. So in the investigation of sudden unexplained death, an APHR should be taken to obtain detailed personal and 3-generation family history as a minimum. And that is where the assistance of a multidisciplinary team comes into play. This should also include the witness accounts. And when in the investigation of sudden unexplained death, there is a need to obtain all prior medical records and relevant investigation from the decedent, proband, and the family members. So this is a flow chart. There is a sudden unexplained death. Multidisciplinary team comes into play. They make a 3-generation family history and a personal history of the decedent. And if there are more sudden deaths in this family history or more relevant issues, that should all be brought up here. It's important to find out what the circumstances of death were, whether it was an adrenergic sudden death, whether it was a febrile illness. The age and gender are obviously important, and all this information can put you at a certain in the direction of a certain diagnosis. Obviously, also a prior history of syncope, seizures, chest pain, exertional dyspnea is of importance, relevant to non-cardiac features, and if there is any prescribed medication. All that should be acquisited as a class 1 recommendation. Genetic counseling itself and genetic testing itself is strongly recommended for all families where there has been a sudden unexplained death or resuscitated cardiac arrest with a potential heritable cause. And I have mentioned that it should include all the relevant data. And it is when you start doing genetic testing, my final slides will be on that. Genetic testing itself, it should not be performed without appropriate genetic counseling. That's a class 1 recommendation. Now, there are 2 settings where you can do genetic testing. One is the setting where the sudden death, where the phenotype is known, and the other setting is where the phenotype is unknown. And I will discuss both of them in somewhat more detail. So this is where the phenotype is known. There is a sudden cardiac death. There is a diagnosis mostly established at the postmortem. The decedent can be a family member of a known pedigree, and then you can obviously go class 1 recommendation for targeted genetic testing for the familial variant. When the decedent is the proband, so nothing known in the family yet, then you should take care of the family, evaluation of the family members, pedigree, genetic counseling, and clinical evaluation. And you can go on with targeted genetic screening in the proband based on the clinical phenotype identified at autopsy. So if you find hypertrophic cardiomyopathy at autopsy, the genetic testing should be targeted to hypertrophic cardiomyopathy. That can lead to either the identification of a pathogenic variant, which allows cascade variant-specific genetic testing in the family. You go back to the family. And ongoing family care for affected family members. And in case that is requested, reproductive genetic counseling and management for affected family members. You can also identify, of course, a non-pathogenic variant, and that variant needs follow-up because over time, a class 3 variant, which will usually be the case here, will either be upgraded because new information is published somewhere in the literature, or it can also be downgraded because it's now for sure that it's not relevant to the disease. So non-pathogenic variants should have follow-up over time. And you need to have a system in place for that. When the phenotype is unknown, so the sudden unexplained death with no diagnosis or phenotype established after extensive family screening or autopsy, there are a number of options. When there is a documented arrhythmic death suggestive of arrhythmia syndrome, you can continue as a class 1 recommendation with genetic testing. That would be then an arrhythmia syndrome focused genetic test. This can also be the case if the sudden cardiac death is preceded by specific triggers associated with familial arrhythmia syndromes. So exercise-related death, swimming-related death, etc. In the case of young age, and that is defined here as below 40 with a class 2A recommendation, you can go on with arrhythmia syndrome focused testing. But we do not recommend hypothesis-free genetic testing with a class 3, no benefit. And the reason for that is emphasized in the next 2 slides. This is first the role of genetic testing in unexplained sudden death. This is a review by Chris Miles and Elijah Behr, published in 2015. And it shows the yield of molecular autopsy after sudden arrhythmic death syndrome. The CPVT genes are here, the Lon QT genes are here, and other pathogenic mutations are here. And you can see it's roughly 11% across different studies, 13% across different studies. I'm not sure all the genetic data here are really true. Another pathogenic mutation also in this order. So the yield is in the range of 15 to 20%. The backside of this is that, and that is certainly true if you have these larger panels, is what Mike refers to as genetic purgatory, and that is exposing the variants of unsignificant and unknown significance. So the more you screen, the more variants of uncertain, unknown significance you find. And in this case, you find them in individuals who have died suddenly. And then the family and the doctors, they all become nervous because something has been found that could be related to the disease, but there's no certainty around that. And that can lead to terrible situations. This is another a paper from the Mayo Clinic by Mike's son, and Mike is a senior author here under the beautiful title of The Promise and Peril of Precision Medicine. In this particular case, there was a misinterpretation of a KCNQ1 variant that actually led to 20 plus unneeded ICD implants of carriers of this KCNQ1 variant that after a second opinion in the Mayo Clinic didn't appear to be functionally relevant. Instead, the disease died from a Desmond variant, if I recall correctly. So it's not without risk to do genetic testing unless you do it in an experienced center. So, and this is where Dr. Behr will catch up, chapter 7, the investigation of sudden cardiac arrest survivors. So I'll stop sharing my screen and Elijah will take over.
Thanks, Arthur. So my screen should still be apparent there?
Yeah, it's there.
Great. Okay, so chapter 7, chapter 8. Now I'm not going to go through all the tables related to chapter 7 and 8. I'm going to just run through what they cover, and you can see these in the documents. I think they're available without charge online, open access. And then I'm going to try and show you maybe a workflow that may be most amenable for evaluating sudden cardiac arrest survivors after their first resuscitation, and providing, of course, they've successfully resuscitated. So the tables would say that you have to evaluate the history of the individual, their personal and family history, the circumstances of their cardiac arrest, all possible details surrounding it. It'll emphasize as well the importance of doing an initial physical examination, and then undertaking a range of baseline investigations ranging from initial ECG bloods, retrieving recordings from the AED or from any wearable devices or even implantable electronic devices the patient may have, and going on through the various different ECG and imaging modalities that may be useful in or essential in the investigation of the cardiac arrest survivor. And you'll see, as Arthur mentioned, all these evidence are either B or C, a level of evidence. Many of them, of course, are strong recommendations. And then there is the additional range of investigations, provocative testing, including pharmacological challenges, electrophysiological study, and exercise challenge and orthostatic challenges. Finally, with genetic evaluation. So if I just take you then through that in a more, less didactic way, and hopefully a more interesting way, we start off with the resuscitated sudden cardiac arrest survivor with witnessed VF in general. We'll have the 12-lead ECG seen during sinus rhythm, and it may have the arrhythmia. It may have other features on it. The most important thing, of course, is to exclude ST elevation myocardial infarction, which would immediately lead onto primary intervention to rescue myocardium as well as to stabilize the patient. And of course, we may already have signs on the ECG of the underlying etiology of the cardiac arrest. For example, we may have pre-excited AF in the setting of Wolff-Parkinson-White syndrome. We may have evidence of Lon QT syndrome already, abnormal T waves, clear evidence of severe QT prolongation in this case. We may have evidence of J-point and ST elevation of a cove nature, the type 1 Brugada ECG pattern in the right ventricular leads. And that can be dynamic and change. And we may even see evidence for marked J-point elevation in the infralateral leads, the early repolarization syndrome, as shown over here, with short-coupled torsade de pointe ventricular ectopic activity triggering the arrhythmia. Or we may see other signs that are maybe less specific, but in the context may immediately raise concerns, such as this T-wave inversion seen in these V1 to V3 with right ventricular outflow tract ectopic beats, suggestive of underlying arrhythmogenic right ventricular cardiomyopathy at the outset. The next step, of course, as part of the emergency, is the physical examination and understanding the history of the presentation, because we want to ensure that we're not missing anything that could require immediate treatment, such as intracerebral hemorrhage, subarachnoid hemorrhage, or aortic dissection or rupture. That could be an acute emergency. We can then think about family history in terms of genetic causes when we're trying to gather the background of from the family as the individual arrives. But then the bloods will be taken, toxicology, and we've recommended as well, and this is all green recommendations, that EDTA blood samples are stored for potential DNA extraction in case a genetic cause is considered. And then this is these are the recommendations around retrieval of recordings that give information around the etiology. Maybe one would see bidirectional polymorphic VT, torsade de pointe, that may give a greater evidence for an underlying cause, or maybe a very rapid monomorphic VT retrieved from the AED that had caused the cardiac arrest. We recommend as well high precordial lead ECGs to diagnose Brugada syndrome. And this is where leads V1 and V2 that normally sit in the fourth intercostal space are elevated to the third and the second intercostal spaces and are more sensitive for the type 1 Brugada ECG pattern and could be missed if the dynamic pattern is not anticipated. These could dissipate after the cardiac arrest. Then we also recommend continuous ECG monitoring of the patient for any more evidence, including for arrhythmia triggering, and that may reveal evidence for coronary spasm or may show evidence for short-coupled torsade de pointe, as in this patient who didn't present with early repolarization syndrome, but had a clear IVF with short-coupled initiation. And then we have to think about imaging if we haven't got our diagnosis as yet. Cardiomyopathy and valvular disease can be readily diagnosed with echocardiography in the urgent and emergency patient, whether bedside or done more formally a little bit later in their recovery. If no cause is identified, then we do need to think about further testing. And this is where more sophisticated imaging will come in, including MRI with late gadolinium enhancement, which we've recommended in general across the board to assess acute or chronic cardiomyopathic disease, and that it may also be or can be useful as well as a baseline test, even if the patient may have underlying ischemia or inflammation as the cause of the cardiac arrest, rather even in the setting of underlying genetic heart disease. Coronary imaging may also be indicated, particularly in the older patient, to exclude coronary disease specifically, but also to consider dissections and anomalies that may be a cause of cardiac arrest in younger patients. The single average ECG may be considered and may be useful for the diagnosis of arrhythmogenic cardiomyopathy and Brugada syndrome, but exercise testing is strongly recommended and should never be forgotten, and often it is forgotten, and there are data on this being missed. It can be useful for a number of diagnoses, predominantly Lon QT and CPVT, but could also be important for diagnosing concealed Brugada or arrhythmogenic cardiomyopathy. And this is just an example of bidirectional polymorphic VT and also just bidirectional ectopy being picked up on the exercise test for a CPVT patient. Lying to standing ECGs can also be useful. So that's the yellow color, class 2A, particularly for Lon QT syndrome. So the orthostatic change here in a patient who has a normal QTc interval at rest and then has a marked QT stretch as proposed by Sami Viskin and validated by others. And so that could be a useful test subsequently. And we often combine the lying to standing ECG with the exercise test into one protocol. The other bugbear here is epinephrine challenge, which is a 2B indication, so may be considered. It certainly may be useful in inducing ectopy in the patient with CPVT, but sometimes isoproterenol may be better from that point of view, and may have a role in Lon QT diagnosis in patients who cannot exercise. There are concerns about reproducibility in a general population. It's certainly useful in a Lon QT population on its own, but not necessarily in the cardiac arrest survivor population. And then there's sodium channel blocker challenge, and where there's already a high suspicion of Brugada syndrome with a type 2 or 3 ECG pattern, it is thoroughly recommended, whether that may be ajmaline or procainamide, and then should be considered as a class 2A, even if the type 2 or 3 ECG pattern may not be present on the resting ECG. A high lead ECG may often give this away anyway. In this case, we've got an individual here who had standard ECG leads without significant evidence of a type 2 pattern in the left side on their resting V1, V2, V3 in the fourth intercostal space, but with sodium channel blocker challenge induces the type 1 pattern. Other challenges may be considered as well, although in selected patients more likely, gonadine and acetylcholine for coronary spasm, even hyperventilation may be of use in these patients, and adenosine may be useful for exposing Wolff-Parkinson-White syndrome. EP studies can also be considered when there's a strong likelihood of underlying bundle branch reentry or pre-excited AF atrial tachycardia, as you saw, and sometimes EP study and RV mapping may be useful for diagnosing underlying arrhythmogenic cardiomyopathy. And in very experienced centers, epicardial mapping may be useful for identifying the substrate in concealed idiopathic VF. So that's a long pathway of potential additional testing that may be considered, but many are strongly recommended, and I'll summarize those at the end. In terms of the role for genetic testing in the sudden cardiac arrest survivor, if we have the genetic phenotype identified or suspected already, then there is a clear class 1 green role for phenotypic specific genetic evaluation, so targeted to the individual's phenotype, and the possibility of having a broader based genetic evaluation in case the phenotype specific evaluation doesn't pick up the finding. But again, you've already heard from Arthur about the risks of variants of uncertain significance and genetic purgatory described by Mike. If no genetic phenotype is suspected or identified, and a non-genetic cause for cardiac arrest is identified, then again, it's a class 3, no use of genetic testing in this setting. It's a waste of resources, and it can only potentially cause harm rather than benefit. If, however, there is a suspected suspected genetic cause, then a channelopathy or cardiomyopathy specific genetic evaluation may be considered. And we'll just review a little bit of the data around that. If no cause is identified at all, remember in the cardiac arrest survivor, that's idiopathic VF. In terms of the yield from the CASPER registry, that probably gives us the best understanding of the utility of that sort of protocol that I've shown you already. We'd be able to diagnose just over 50% of cases where the cardiac arrest is without an obvious initial cause from that initial ECG and evaluation. And you'll see that cardiomyopathy and channelopathy are well represented there, as well as a smattering of spasm and myocarditis, vasospasm and myocarditis. Just under half would still be described as idiopathic VF, and genetic testing in idiopathic VF may still give some utility. In this work also from the CASPER registry, pathogenic variants were picked up in between 8 to 21% of cases, depending on the extent of the panel involved. But you'll see again, importantly, while the proportion of pathogenic variants is impressive with smaller panels, it becomes less impressive and is drowned by VUSs when you have a very large multi-panel, multi-phenotype panel. So you trade off some risk there for benefit, but it may potentially be useful. So in terms of investigation of the family, if you do identify a pathogenic or likely pathogenic variant that fits a phenotype in a sudden cardiac death proband or in a first-degree relative, or in postmortem or in assessment of the proband that survived, then that can be used for ongoing clinical evaluation by testing that individual as positive and excluding others who do not need ongoing evaluation by testing them as negative. There's also a recommendation to encourage cardiac arrest survivors to share information with their relatives about their underlying condition, and recommendations around the need for further research to assess the utility of genetic variants for follow-up of patients in a clinical trial setting. And again, the recommendations around the need for genetic counseling. In terms of investigating the family, I'm now just going to take you through a flow diagram from that point of view. Family evaluation focused on the first-degree relatives, although you may wish to consider obligate carriers or symptomatic relatives as important people to prioritize, particularly the symptomatic. And if you already have the molecular autopsy or the decedent having a positive cascade test, and then this could be applied immediately in family evaluation in the setting of unexpected sudden death and unexplained sudden death. So those are all green, strong recommendations. It can also be useful to to undertake the initial evaluation in family members, personal family history, physical examination, resting ECG with high leads, exercise ECG and echo. That's the basic protocol, considering the possible usefulness of 24-hour ECG and CMR, that's 2B. If there's a high index of suspicion for Brugada syndrome, then sodium channel blocker test can be useful. If there's a low level of suspicion, it's going to be less useful. An epinephrine test may be considered, although again is going to be less useful. In terms of how the data are for idiopathic VF patients and their family members, going through that very comprehensive protocol, the yield is pretty low. Most family members won't have a diagnosis. A small proportion may have a positive sodium channel blocker test indicating concealed Brugada syndrome, and there may be a role, particularly for genetic testing in some groups, and in this case it's the Dutch population that are included in the study where there's a particular risk haplotype, the DPP6 risk haplotype. This is one of those families where an IVF survivor, despite being thoroughly evaluated, has a father who has clear evidence for Brugada syndrome based on sodium channel provocation testing. There is also an excess of the early repolarization pattern in family members of idiopathic VF survivors, suggesting that J-wave syndromes are going to be an important underlying risk in idiopathic VF. And if you look at uncertain phenotypes where the decedent hasn't survived, that's the SADS case, then there is a diagnostic yield from clinical evaluation that is actually pretty impressive, ranging from around 3% in this particular summary for CPVT, 10% for Brugada, 11% for Lon QT, 7% for others, her overall diagnostic yield of 30%. And from our own particular experience, we get a diagnostic yield of over 40%, with the main diagnostic yield being Brugada syndrome using Ashmolean provocation testing. The molecular autopsy may help as well, as you've seen already. It can help to improve the understanding of the etiology of sudden death in a family. And we've shown this in a large international study of over 300 cases, where we found a yield of 13% of pathogenic and likely pathogenic variants. Studied these in families subsequently. The main diagnosis was CPVT, but Lon QT was the next up. But when we looked at families, we found that this application of the molecular autopsy increased yield significantly, particularly in the channelopathies and the cardiomyopathies by around 50%. So in conclusion, the optimal evaluation of the sudden cardiac arrest survivor is comprehensive evaluation driven by the ECG, imaging and provocation testing. The optimal evaluation of the family is focused on first-degree relatives, symptomatic patients and obligate carriers. Sodium channel blocker testing is important in terms of its yield. For Brugada syndrome, and MRI plays a role as well. In SADS, that yield can be up to 40%, so that's the unexplained sudden death group. In idiopathic VF, the yield is low, but there is this concern about concealed Brugada syndrome, and that deserves a bit more investigation. In terms of genetic testing, it's cost efficient and high throughput with current technologies, gives you the likely cause in around 13% in SADS, similar amount in idiopathic VF, but predominantly from the myopathic, cardiomyopathic genes, and can work synergistically with family evaluation. Thanks for your attention on that.
Thank you, Elijah. Mike, are you going to lead the discussion?
Yeah, that was great. Well, they haven't roomed the patient yet, so this is fantastic. I got to enjoy both of your presentations. So on behalf of SADS Foundation, thanks a lot. And again, we couldn't do this without Invitae's support or Medtronics. So thanks again to them. Before I take the question, and please in the chat box, I'll look along the side to see what questions you're posing, and I'll do that until they get this first patient. Let me ask a different question. As I size up the field, at least here in the United States, I would call it a total mess. So I think the evaluation of sudden cardiac arrest survivors, their families, the decedents, their families, is unbelievably heterogeneous. It varies from, at most, condolences to, on the other end of the spectrum, seeing patients and their families getting every single cardiac test ordered and repeating it every year or every 6 months or every 3 months. I've seen a phase where we didn't even have medical examiners procuring sample in a DNA-friendly way, so we couldn't even do a molecular autopsy. Now I see where the medical examiners, when they find nothing, they write out on the cause of death, must be Lon QT syndrome. I see where evaluation of survivors and their families, a tremendous overdiagnosis happening, as if we've got to somehow find some genetic heart disease to name this family with. And then we have not only genetic purgatory of variants of uncertain significance, we have findings of uncertain significance, FUSs, and we make a lot of fuss about the fusses. And so I'm curious, in your countries, one, do you agree with that? And then two, if so, let's do the Scott Van Pelt, famous guy on ESPN. He has the one big thing segment to his show, as in, what's the one big thing that you would want people listening to stop doing, and the one big thing that they must be doing in these evaluations to be making a difference? So size up the state in your country. Is it as Wild West heterogeneous as what I'm observing here in North America? And then the one big thing that you would want people to stop doing in this area because they're doing it poorly, or start doing because they haven't been doing it. Arthur.
Okay, so I think it's less of a mess in my country, and that may also relate to the fact that it's obviously a much smaller country, and my colleagues are more eager to refer their patient or their family to us right away before doing anything themselves. So I think it's a very, very low threshold for referring patients to centers of expertise that not necessarily have to be us. It can be another academic center. And they're always nearby because of the size of the country. So I think the problem is less as it is. And on your other question, the one thing that people should do is, I would say, follow these guidelines. I think the reason why we wrote these guidelines is exactly to minimize the issue that you raised. And if you follow the guidelines, then I don't think you can make these miscues. And if you ask for a specific test, what I would not do or not recommend to do is genetic testing without appropriate genetic counseling. I think that is not the case in the United States. Everybody can still order a genetic test without appropriate or proper genetic counseling. That is the one thing I would not do. And the one thing I would do is, I think one of the issues that often lacks, and you've shown that yourself in one of your studies, is an exercise test, which is quite frequent, not present in the basic evaluation of the survivor.
Elijah, how about you?
I think Arthur's stolen my thunder there. The whole guidelines. I think that's a good answer. I think I think in our country there, with a socialized healthcare system, there is good access overall to a similar level of standard of care, and there is a willingness to refer for these sorts of evaluations. So I think that it's again a smaller country than the US. So I think there is advantage from that point of view, and the emergency services for treating cardiac arrest survivors is pretty good. In terms of the sudden death families, there is a recognition that these need to go to specialist centers from that point of view, and there's a network of those around the country, about 17 at last count, I think. So that I think we're reasonably well provided for, but there's still a lot of work to do. there are a lot of sudden cardiac death cases where families don't get referred. So I suppose the thing that I would want the most is that coroners and their pathologists highlight and accept that there are cases of unexpected and unexplained sudden death that they can't necessarily find the answer for, and that needs expert pathology and expert evaluation, and that can then trigger the right pathway for the patient and the family. There's nothing worse than missing the diagnosis and another death happens, or not referring at all because the diagnosis hasn't even been considered. So my plea would be around pathology and its appropriate use for the sudden cardiac death patient. In terms of what I would wish to avoid the overuse of, I do have a bugbear with epinephrine challenge and its specificity in the populations that we've been addressing in the sudden cardiac death document, and so I would advocate against that. I think it's got its place in other settings, but not in this population.
Yeah, just to follow up on that, I mean, as you know, we and Dr. Shimizu in Japan essentially established the epinephrine QT stress test in the era long before genetic testing, and when interpreted well, it's a very good test for unmasking type 1 Lon QT syndrome, for which we now know how we can do it by stress testing and by genetic testing, where there's a 2-week turnaround. And so, and the other thing we saw with the epinephrine stress test is that people just didn't know how to interpret it because it brings out funky U waves. And if you don't know how to censor the T wave from the U wave, you will get this false appearance of a faulty T wave and gross QT prolongation when it's just a young woman with an accentuated epinephrine augmented U wave. So in other words, we got handicapped on interpreting that test. And I would suggest that we may well be suffering from the noise with the standing QT stretch test. I know we put it in the guidelines. Sammy Viskin's data, as he discovered it, is really helpful. But as the standing QT stretch test is getting used in clinical practice, I think it's suffering from the same false positive overinterpretation that we started to see with the epinephrine test. Are you seeing that with the standing QT stretch test, that it might be precipitating an overdiagnosis? Because we certainly have seen that.
In children, definitely. So in young individuals, I'm not sure about adults. I think in adults is pretty reliable. And I agree with the comments on the epinephrine stress test. But I think in the document, we explicitly limit that the use to individuals who are not able to stress. So if you have a resuscitated individual who's in unconscious and remains unconscious, and you still want to do some diagnostic test, then the epinephrine test might be a useful thing to do because you cannot do a stress test.
Right.
In that sense.
Arthur and Elijah, we have a question from Allison Krizwanczyk, and I'm sorry, Allison, I probably did terrible on your last name, but she's wondering, does the rhythm after defibrillation maintain significance? Do you need to be interpreting the rhythm pre-shock? How do you use that when you get an AED trace? Well, one, a plea to the first responders, save the AED trace for us. That would be a plea. But let's say you're provided that. What do you do with that?
Well, if we've got it, it can obviously be, it can be useful in terms of guiding the diagnosis. If you've got a clear rapid monomorphic VT rather than a VF or a polymorphic VT, then it's going to lead you down a potential different diagnostic trail. You'll be thinking more about underlying ischemia, structural heart disease, rather than necessarily going to the primary electrical syndrome route. But obviously most of these patients won't have the pre-shock rhythm or the pre-ventricular arrhythmia rhythm available unless they've got a loop recorder in, and you won't necessarily see that in initiation, which I think is why you've got it as a class one recommendation, if you can get the pre-shock rhythm or the pre-rhythm readout, the pre-VA readout, and that it's only class 2B if you've got the rhythm after the shock has been delivered, because the utility of that and the specificity of that is going to be less significant.
Yeah, I have nothing to add. I think that's what it is.
And Julianne Wojciak asks about commenting on the utility of postmortem genetic testing and first-degree relative cardiac testing in SIDS versus SADS. And I think your comments about SADS and essentially the guidelines, the age really kicks off at age 1 or greater. And I could take the SIDS. For 20 years now, we have been investigating now, along with Elijah, the genetic basis of SIDS. And no matter how hard we try, we cannot get the monogenetic incidence of SIDS, monogenetic heart disease, to be higher than 10%. That's the signal. And if that infant death happened between 2 to 4 months of age, sort of classic epidemiologic infant death, the yield is even lower. If it actually happens in a 6-month to 12-month, the yield is closer to 20%. And so even under age 1, we're probably going to have to refine this. So we do a screening ECG in all infant deaths. We do it, but we expect that we don't have to force all of these infant deaths to be Lon QT syndrome. Almost all of them won't be. Less than 10% will be. So you just have to keep your pretest probability clear in view with each patient population you do. Elijah, do you do a first-degree relative ECG in the mom and dad and siblings of a 3-month-old infant death?
We have done, yes. I have to say the yield is nothing at the moment, really. Very occasionally we've had success in finding a molecular autopsy result that may be meaningful in a family, but it requires very careful consideration, because often the penetrance, the expression of the variant in the parents and in other siblings may be difficult to interpret. I think it's a real challenge from that point of view, and we don't want to ignore the fact that SIDS is a multifactorial condition in which we expect that there are 3 different major influences going on, not just the genetic predisposition, but also how vulnerable the infant may be at that particular time in their development, as well as the challenges that may meet the child, the infant, in those first few months of life. So I agree with you. It's not an easy clinical area to be able to work in and get good results for families.
Well, we have 100 participants still with us, so please ping me a question in the chat box and I can send it to Arthur and Elijah for their reaction. But I want to, while I'm waiting for one, Arthur, I think you have an incredibly important paper that not enough of us in the field use or communicate effectively to the family. And that's your data about the good news as when you evaluate a family over and over again and nothing's found, that even though you might not be able to explain that sudden death of that 24-year-old, that when you do that rigorous evaluation in the decedent and you can't give an answer, and then you do an evaluation systematically in that decedent's brother, sister, mom and dad, and you don't see anything in them, that tragedy basically never strikes again. Can you comment more on that? Because I think our field has missed that. And because they missed that importance, it just seems like our colleagues try to force a diagnosis onto these families of some sort, feeling that somehow that gives better closure than saying that we can't find anything.
Yeah. Thank you for putting attention on that paper, Mike. It is a couple of years ago, and it is on the, from the top of my head, it was about 80 families with a unexplained sudden death at young age. And we investigated the families according to what we now wrote in the guidelines. So there was an echo, there was an exercise test, there was an EKG, blood testing for cholesterol, and physical examination, and nothing was found in these families. There was only one family where already 2 individuals died suddenly, and the only event upon a follow-up of about 5 years, mean follow-up was about 5 years, was an event in that similar family where already 2 individuals died. So there was a 3rd one who had a cardiac arrest. And in the other 79, in the absence of any findings in the family members, in the absence of any findings in the decedent, him or herself, nothing happens. So I think that points to the fact that potentially is a non-genetic cause of death, and then the family members are not at risk. And then it's unfortunate that you cannot give the family a diagnosis, but the good news is that if you have looked at all the relevant individuals in the family and you don't find anything, then they don't have to be nervous that something might happen.
And Elijah, how long do you keep those families in the queue? So we do our due diligence. That molecular autopsy, the standard autopsy, was truly negative in the decedent. You then did your drill on his or her first-degree relatives, and you're not finding anything. You're not going to overdiagnose on the SAMI stretch. You're not going to do the epinephrine and overdiagnose Lon QT1. You're not going to potentially even do, shall I say, Ajmaline and overdiagnose Brugada. So how often will you keep that family in some sort of a drill? Do you then extend them to every other year, every 3rd year? Do you ever dismiss them? I think all cardiologists would really like some guidance on that because they don't know what they're doing.
Yeah, I mean, I have quite a systematic approach, or our team has, and as you said, the Ajmaline provocation test is an important part of our protocol. It is a potent test, and so if I have families where that test is negative, as well as all their other tests, then we discharge them from follow-up, because we also believe that there is a very low chance of risk for those family members. The proviso is that, of course, if somebody becomes symptomatic, that they have immediate access to return, either as an emergency or as an urgent clinical follow-up. And of course, if the family history changes, somebody else in the family dies, and then or a disorder is picked up, then that will also influence the change. So sometimes we see concealed cardiomyopathy emerging in a family member that we may not have suspected otherwise based on the basic on the testing. The other proviso is for children, because there are some disorders that are going to be more expressed as the children get older. Clearly, Lon QT or CPVT, we're expecting children to have expression. But for cardiomyopathy, and as I said, there are a small number of cases still in there, as well as Brugada Syndrome, we're expecting a later development in phenotype. So we will still offer children follow-up, although it will be at longer intervals once they've completed most of their testing and they've passed through, and they're passing through puberty or passed through puberty. I want to just say about sodium channel blocker challenge in Ajmaline. There is a chance, of course, that if you're going to use it indiscriminately, that you're going to overdiagnose Brugada syndrome. But I think you have to think about the context of what your investigative protocol is doing. You are excluding all other conditions, and then you're an enriched population where most of them are young males, relatives of young males who died in their sleep. And in that setting, I think we do have to think about the role for sodium channel blocker challenge. The yield is substantially greater than you expect from a false positive result in this population.
So a quick follow-up, Arthur, on that. Would you be a one and done evaluation in your program so that 24-year-old decedent, his 18 and 16-year-old siblings and mom and dad have a normal evaluation? Are they dismissed unless they call you with a symptom or a new family history, or would you do another one?
No, we see them every 5 years until they are 40 and dismiss after 40.
So we've got some great questions, guys, coming in. So we'll do a little bit of rapid fire round now. This one's from Ruth Biller. Thanks, Ruth. What do you recommend if you have a really typical phenotype? She's not saying which phenotype, but a VUS in genetic testing after the sudden death or survived SCA. And let's assume that she means a VUS in the gene for that phenotype. Do you offer family screening in this case? How often do you recommend to reevaluate the variant if it is upgraded to class 4 or 5 in the meantime? I guess class 4, she means ACMG, likely pathogenic, class 5, now pathogenic. So I think part of it is, I don't really care what the genetic test company calls the variant. I'm sure you have the same situation, Arthur, where you've taken a VUS from a company and in a split second said, that's not a VUS, that's the patient's disease causative variant. But comments on that?
That is what you refer to as phenotype enhanced mutation calling. That's what we have done for CPVT together. You're working on the Lon QT syndrome, and I think this should be done in every disease entity. And if the phenotype is strong and you have a VUS in the gene that you expect to be the gene of interest, then with phenotype enhanced and mutation calling techniques, you can actually upgrade the phenotype. But if you end up with a class 3 or class 4 variant, I think you should still offer family screening separately, because if there is a phenotype in the decedent without a genetic test result, family screening is pertinent also, and it's also pertinent in the setting of a class 3 or class 4 genetic variant.
Yeah, that would be on my wish list for the one big thing for genetic test companies, because right now in the United States, if they've concluded it's a VUS, they will often say this variant is not eligible for family testing. And I think that that testing is in fact one of the most helpful exercises for people like us. Now, I get why they're doing it, because VUS testing run out of control with people who don't know how to spell DNA will just be awful, right? But I think, don't you agree that when you do family variant testing, that often helps you and me tremendously with what we're doing with the family, even if it started being called a VUS by the particular gene test company?
Yeah, the problem with the gene test companies is obviously that they don't have the full information on the phenotype, whereas we do have that, and that is, and we should use it, of course.
So Elijah, they're asking from Serena, any suggestion for the medical examiners after a positive drug screen? Is there data on these SADS cases getting dismissed as a drug overdose diagnosis? Meaning, yes, there might be a positive drug screen, but before you too quickly write that off as explaining everything, should they be doing something more? Have you seen that where you've had the drug screen being positive for something, but there was more to the story? In fact, the molecular autopsy revealed the truth. I'm thinking of Dan Roden's drug-induced Lon QT syndrome papers, for example. Thoughts about that?
Yeah, I think there are occasional cases where you do see that, but of course you're dealing with a denominator where you just not necessarily you're not getting to the underlying or mislabeling of cases just because they don't get referred, and their DNA doesn't therefore get collected, and therefore you don't make the molecular autopsy diagnosis. Thankfully, I think that's not so common. But where I think the issues are, where there are drugs of abuse such as cocaine and amphetamine involved, where we know that those are stimulants that can potentially cause risk in some phenotypes, and those cases may get dismissed out of hand by medical examiners and coroners. But it's actually, in my experience, I've found that to be uncommon. But I wouldn't be able to say for certain because, as I said, the denominator is still unknown.
Great. And this is from Mariana. It's a great question. We might have 3 different answers, so this will be interesting. In case of sudden cardiac death, where the autopsy is normal, negative, what would be the right genetic panel that you utilize if you decided to, well, one, do you do the postmortem genetic test, molecular autopsy? And if you do, what do you order? Do you order the comprehensive arrhythmia cardiomyopathy panel? Do you do the exome? Do you do something different? What do you do in that situation? We'll start with Arthur and then Elijah, and then I'll tell you what I actually do too.
So we actually discussed that in the presentation because it was one on the slides. And the first question indeed is whether you should do it at all. And I don't think outside the center of expertise, you should not order a genetic test in such a case. But if you are in a center of expertise and you know how to handle all these genetic results that might turn up, you can still do it. And it depends on the whether you do an arrhythmia-specific test, if you had clues in the medical history of the decedent or in the family. You can do an arrhythmia-specific test. When you have, when the patient is of young age, under the age of 40, as I mentioned, it's a class 2A indication for arrhythmia-specific test. But when the patient is much older, I think I wouldn't do it at all. So if you would do it, I would do an arrhythmia panel. Occasionally, you can consider a cardiomyopathy panel because there are some of the genes that are in the cardiomyopathy panel that might be of relevance in a case where the autopsy is negative and still a variant can come out. I would never do an exome in such a case.
Elijah?
Yeah, in research, we do exomes and whole genomes, but that's a different matter. For a clinical test, we go for an arrhythmia and cardiomyopathy panel with high coverage, and that's what's available through the National Genetic Service in the UK. And my view is personally that I think we do need the cardiomyopathy panel element of the test, because there is this concealed cardiomyopathy which particularly may affect may have caused the death in older cases, arrhythmogenic cardiomyopathy in particular. And I think that while we're doing work to show that scientifically, and that it's important to consider still, there's enough anecdotal data from our colleague Chris in Australia in particular, Chris Samsarian, that they've found it in there as being relevant in their cases of unexpected sudden death. So yeah, I would go for a comprehensive arrhythmia and cardiomyopathy panel as the clinical test, and an exome and whole genome for research.
Great. And that's essentially what we do here at Mayo Clinic as well. We do routinely a molecular autopsy in all sudden cardiac death victims under the age of 40, like Arthur said. As they get older, I think you have to be really careful unless there's signals. We do the same test on everybody. It's utilize the Invitate test, but it's basically what Elijah said, the comprehensive arrhythmia and cardiomyopathy panel. But that's because you and I also know what we're dealing with. I want all of the data. But we, like you, are very, very careful with analyzing or interpreting, finding something in any of 100 plus of those 153 genes. Because if you have something rare in a minor gene, we better be very careful before we're going to call that the cause. So a major channelopathy gene, a major cardiomyopathy gene, it will catch our attention. Research mode, I agree, Elijah, we're now doing the whole exome molecular autopsy, but we always do that with the trio. So the decedent and both parents, if possible, if there's no information, because otherwise I think interpretation of that data set, a sudden death victim in isolation, his or her exome is going to be almost impossible to interpret. The parental DNA information is somewhat helpful. Well, we have reached the end almost. For those of you who've joined, it's been great having you, Arthur and Elijah. This has been a wonderful webinar. Marcia, thanks so much for organizing this. And Marcia, from the staff of the SADS Foundation, any parting words for everybody?
I would just echo what you said. I thank Doctors Behr and Wilde and you, Mike, Dr. Ackerman, for your participation today. And I thank all of the attendees who had some great questions and participated. And once again, if you really learned from this webinar and enjoyed it, I would say consider a donation to the SADS Foundation at stopsads.org.
That's great. Thanks, everyone. Have a wonderful rest of your Friday or your Friday. What day? No, Tuesday. Your
Tuesday.
rest of your Tuesday or your